Malignant ovarian neoplasm is a third most common genital cancer in women, but constitutes number one mortality in women from genital cancers. It can be grouped into three major groups: epithelial ovarian cancers that arise from the germ cell, and sex-caused stromal tumors. Of this, the most common is the epithelial ovarian malignancy, which is again divided into serous and non-serous type. Of this, the serous type is most common, which is again divided into low grade and high grade. The non-serous variety, the most common is the endometrial type, which constitutes about 10 to 15% of the malignant ovarian tumors, and other non-serous varieties are squamous, clear cell, and neuroendocrine tumors. In this session, I am going to discuss on high-grade serous epithelial tumors. Majority of these high-grade epithelial tumors are detected in the advanced stage, and hence the survival is very much affected, which is less than 50%. But in recent advancement in medical and surgical treatment, introduction of targeted therapies and biomarker targeted therapies have revolutionized the treatment of these high-grade tumors and has improved survival. Genetic screening is recommended in all cases of this ovarian malignancy except in mucinous ovarian tumors. Age is an important risk factor for ovarian malignancy. As the age increases, the chance of malignancy also increases. The incidence of malignancy when there is an adnexal mass in a reproductive age group is about 30 to 35%, whereas the chance of malignancy increases up to 50% in a postmenopausal woman. It is rare in young girls and adolescents. PCOS, nowadays called polyendocrine metabolic ovarian syndrome, is another risk factor. Infertility, endometriosis, and serous sphincting increases the incidence. Hereditary factors like BRCA1 has a chance of 30 to 50% chance of developing ovarian malignancy, BRCA2 about 5 to 10%, and Lynch syndrome has a chance of developing hereditary ovarian malignancy about 1 to 5%. High-grade ovarian tumor is notorious for asymptomatic in the early periods, and hence it is called a whispering tumor in women. Because in early stages, most of the symptoms are non-specific and may be ignored due to as a consequence of perimenopausal or menopausal symptoms. So Goff has suggested a symptom index, which says that the occurrence of any one of the 8 symptoms like abdominal pain or pelvic pain, urinary frequency or urgency, increasing abdominal size or bloating, difficulty in eating or early satiety. If any of these symptoms occurring for 12 days in a month and for less than 1 year, it should be considered as a positive sign of ovarian cancer and should be evaluated for any presence of any adnexal masses. In advanced cases, women present with mass abdomen or ascites or pain abdomen. Rarely, menstrual irregularity like heavy menstrual bleeding, postmenopausal bleeding can be a presenting symptom, and of course rarely they can present with virilization also. signs, there can be cachexia, pallor, there can be enlargement of the lymph node, especially supraclavicular, axillary, and inguinal nodes. There can be pedal edema, sometimes unilateral due to obstruction of the lymphatic. Ovarian malignancy may be secondary to primary in the thyroid or breast. So there can be enlarged thyroid or salty nodules in the breast. There can be discharge, distracted nipple, mass, or bloody orange signs on the skin. For abdomen, a mass may be felt, which may be solid or solid and cystic. There can be with residual mobility. There can be ascites. The liver may be enlarged. There can be other masses due to secondary deposit like amended caking. Primary examination may reveal an adnexal mass more than 10 cm, unilateral or bilateral, with fixed or restricted mobility. There can be nodule in the pouch or Douglas, but remember, in early stages, all these signs may be absent except for a adnexal mass. It may be unilateral or bilateral and should be further evaluated for signs of malignancy. The primary management is ultrasound imaging of the pelvis and abdomen, which will show features of malignancy like a solid tumor, mixed echogenic tumor, or a cyst of more than 10 cm, unilateral or bilateral. Again, the character of the cyst like multiseptated with thick septa, thick capsule, papillary excrescence more than 4 in number, and the vascularity, low, high flow, low resistance type of vascularity. All this may suggest malignancy. There are different indices, radiological index, ORADS or IOTA index. All these help you to assess the risk of malignancy by ultrasound. Apart from the character of the mass, by presence of ascites, lymph node enlargement, other masses in the abdomen, involvement of the liver, all this may suggest malignancy. CCT will help the pelvis and abdomen, will help in assessing the preoperative staging of the disease. CCT of the chest may also be included to exclude prior secondaries in the chest. PET scan is not routinely done, may be helpful in advanced malignancy, especially in when you suspect recurrence of the tumor. Tumor markers are an important part of evaluation. The most common we do is the CA125. Its normal value is depending upon the menopausal status of the woman. It may be less than 200 in premenopausal, whereas it should be less than 35 in menopausal woman. Other tumor marker, CA is or carcinoma embryonic antigen is can be positive irrespective of the age of the woman. It is the normal value is less than 5, and in small case may be slightly elevated, should be less than 10. Other tumor markers are usually done is CA19. Then if the woman is less than 40 years, tumor markers for themselves should also be done, like alpha beta protein, HCG, then LDH. All this will may help in differentiating a germ cell tumor from the epithelial tumor. MRI may be helpful to assess the staging as well as to know the involvement of other pelvic and abdominal organs with the tumor, which may help in surgery. Laparoscopy may be indicated in advanced stages to assess the operability and also to get a biopsy if you are planning for a neoadjuvant therapy. Women with menstrual abnormality should also always have endometrial sampling to exclude endometrial pathology. Other investigation should be done to assess the performance status of all the comorbidities of the individual, which will help in planning the treatment. The usual investigation done is X-ray test, ECG, liver function test, renal function test, hematogram, bleeding time, clotting time, diabetic exclusion of diabetes, then serum albumin. All this will help to assess the performance status of the woman to withstand surgery. Coming to management, the primary management is primary cytoreduction followed by chemotherapy. Those women, their preoperative assessment shows they have a low morbidity for surgery, and there is a chance of attaining zero or minimum residue can be selected for surgery. And the steps of staging laparotomy should be meticulously followed. Enter the abdomen through a vertical midline incision. Ascitic fluid or the peritoneal washing is collected for cytology. The abdomen and the pelvis is meticulously examined in a systematic manner for any presence of tumor. Any suspected area should be biopsied, and if there is no suspected area, multiple biopsies should be taken from the infracolic gutter on both sides and subdiaphragmatic areas. And surgery should include total abdominal hysterectomy, bilateral salpingo-oophorectomy, amendectomy, plus pelvic and para-aortic lymphadenectomy. If by chance there is a disseminated peritoneal metastasis, only bulky nodes are removed. And to attain zero residue or minimal residue, associated procedures may be required sometime, which includes multivisceral resection, peritoneal stripping, diaphragmatic resection, splenectomy, liver or liver capsule resection. The aim of this extensive surgery is to attain a minimum residue or zero residue, and which because the tissue left behind correlates with survival. In those women who are not fit for primary surgery due to high risk for surgery, or not even if low risk, the minimum optimum residue is not achievable, then we can have the option of neoadjuvant chemotherapy followed by delayed debulking. Role of lymphadenectomy is a little bit controversial. Whether you do lymphadenectomy or not, the survival is not much affected. With lymphadenectomy, it is around 84%, and without lymphadenectomy, it is about 81%. But lymphadenectomy will help in accurate staging and to decide on postoperative chemotherapy. And it has been found that in clinically early cases, there is a 30% upgradation after lymphadenectomy. But it comes at the expense of increasing postoperative hospital stay and increasing surgical morbidity. To avoid extensive lymphadenectomy in unwanted cases, there is a role of sentinel lymph nodes where a dye or either methylene blue or indigo sign is now used, and it can be detected by special probes using infrared. So if the sentinel node is absent, extensive lymphadenectomy can be avoided. And in advanced stages, only bulky lymph nodes are removed. Postoperative chemotherapy is required in all cases of high-grade epithelial ovarian tumor. If it is low-grade and stage 1A or B, no postoperative chemotherapy is required. For chemotherapy, platinum-based chemotherapy gives best result, and the most commonly used is carboplatin paclitaxel 3 weekly for 6 cycles. In advanced cases like stage 4 or inoperable stage 3, or where there is suboptimal debulking in stage 3, there is an option of giving bevacizumab, which is a humanized monoclonal antibody against vascular endothelial growth factor. Other modality of treatment is hyperthermic intraperitoneal chemotherapy, where 100 mg of cisplatinum is used per meter square. It is instilled in the peritoneal cavity for 90 minutes at 40 degrees Celsius. It acts by the hyperthermia is cytotoxic and increases chemopenetration. The problem with this therapy is there is a prolonged operative time, potential toxicity, and postoperative morbidity. It is recommended during interval cytoreduction or in suboptimal debulking. Neoadjuvant chemotherapy is offered for women who are high risk for surgery, or in low risk women where an optimum residue is not feasible during primary cytoreductive surgery. In such people, neoadjuvant chemotherapy using carboplatin or paclitaxel can be given 3 to 4 cycles, and this may cause some reduction in the size of the tumor and make it more resectable. So a complete surgery can be done during the interval cytoreduction. And interval cytoreduction should be done within 4 weeks of last dose of chemotherapy. And this should be followed by 4 more cycles of chemotherapy within 4 weeks of surgery. And before giving neoadjuvant chemotherapy, a histopathological diagnosis is mandatory, for which biopsy can be taken either by a cytofluid cytology or an image-guided biopsy of the lymph nodes, or if this is not possible, even a laparoscopy can be done to get a biopsy sample. Interval cytoreduction is done only when there is some response to the neoadjuvant chemotherapy. Otherwise, if there is no response, interval cytoreduction is not done. Laparoscopy had a limited role in malignant ovarian neoplasm. It may be used for diagnosis where other means of getting a histopathological report is failed, like a cytofluid psychology or a image-guided biopsy doesn't yield any result. Then laparoscopy may be resorted for a biopsy. It also helpful in assessing the possibility of attaining an optimum residue in advanced stages. For interval cytoreduction, it may have some advantage over open surgery because of the advantage of minimally invasive surgery. But during this surgery, you have to take care not to spill the contents into the peritoneal cavity, and endobag should be used for specimen retrieval, and the portals, laparoscopy portals, should be washed with saline, otherwise there will be recurrence of the port. PARP inhibitors like olaparib and niraparib may be indicated for maintenance therapy in women who are BRCA positive and who are in complete or partial remission, and it should be given for 2 to 3 years as a maintenance therapy.